At the onset, I thank the organizer for inviting me and giving this opportunity to talk about this tumors. Basically, it's what I'm going to be presenting is bronchial carcinoid tumors in children and adolescents. Report and management consideration from the German med study group. So it is divided into 5 introduction. So bronchial carcinoid, these are rarest pediatric tumors, accounting for less than 0.1% of all malignant tumors in childhood. The crude annual incidence rate for them is 0.18 per million in children and age below 18 years. While bronchial carcinoid represents only 1 to 2% of lung malignancies in adults, they account for 40 to 63% of all primary lung malignancies in the pediatric age group. Now, etiology of bronchial carcinoma in childhood is largely unexplained. The significance of cancer predisposition syndromes like MEN1 has not been explored. Pediatric bronchial carcinoid have not yet been characterized by molecular genetics also, and they are typically classified into 2 groups: typical low-grade carcinoids, that is less than 2 mitosis per 2 millimeter squared with absence of necrosis; atypical or intermediate grade carcinoids, which have 2 to 10 mitosis and or foci of punctate necrosis, and which have more tendency to metastasis at later point of time. The 5-year survival is approximately 95% in this patient from the population-based data. Thus, the prognosis of pediatric patients seems to be superior as compared to adult patient. 10-year specific disease-specific survival of typical histology is 90% and atypical histology is 65%. Data on childhood bronchial carcinoids actually in the, previously were derived from individual case report and population-based data. Further, there is no consensus on the management of these patients. In this study, they explored clinical characteristics and outcomes in this cohort of patients, and they also propose diagnostic and therapeutic strategy in these patients. This is a retrospective study including the kids, adolescents, and adults in less than 20 years. This was taken from the prospective German registry for malignant endocrine tumor, which comes under German Society of Pediatric Oncology and Hematology. Data for patients' tumor treatment related characteristics were collected from the original data source. Frequency were related to case recorded data. Staging was done depending upon a TNM classification as per the UICC. Then was defined histopathologically, while M was determined by imaging. Atypical bronchial carcinoma defined as more than 2 mitotic figures per 2 millimeter square and presence of focal tumor necrosis. Consent was taken and ethics committee approval was also taken. They identified 32 patients with remaining age and diagnosis of 15 years and a balanced sex distribution of 1:1 for male and female. The median age of male patient were significantly higher than female, that is 16.5 versus 13. The median time from onset of symptoms to diagnosis was 7.3 months. Tumor-related symptoms were present in 27 of 30 patients. Bronchial carcinoma was discovered incidentally in 2 patients. Now, these are the baseline population characteristics for this patient. Coming to the results, the first suspicion of tumor was raised by CT in 14 patients, on pre-radiography for 7 patients, by bronchoscopy in 7 patients, and by MRI imaging in 1 patient. This information is missing in 3 cases. Resection was performed by thoracotomy, thoracoscopy, and bronchial resection in respectively 23, 4, and 1 patient. The method of surgical resection was not validated in 1 case. Resection was conducted as lobectomy in 20, myelobectomy in 6, segmentectomy in 1, and sleeve resection was done in 8 cases. Resection without microscopic residual, that is R0 resection, was performed in 20 cases. R1 and R2 residual were determined in 3 and 1 patient respectively. No resection suggest was reported in 5 patients. Concomitant lymphadenectomy was done in 25 cases. In 4 of those, regional lymph node was diagnosed. Pathological evaluation determined 13 of 24 tumors as T1, 9 as T2, 1 as T3, and 1 as T4. 7 bronchial carcinoid were classified as atypical. This is the EFS curve. At a median follow-up for this duration, this group of patients was 2.7 years. 25 patients were in CR. In 5 patients, due to unspecific nature of the symptoms, it is affected by the median time to diagnose from the date of symptoms. That is, for this cohort is 7.3 months, while another published data is 8.5 months. The predominant symptom is cough, dyspnea, and stridor. It resembles any respiratory tract infection or pneumonia, sometimes mimicking with asthma also. So, and it is sometimes accompanied by bronchial obstruction and anaphylaxis. In contrast to other neuroendocrine tumors, bronchial carcinoid rarely present with carcinoid syndrome. By combining the data outside this publication and this publication, carcinoid syndrome was reported only in 3 out of 92% of these patients. What they suggest is to get CT of chest and at least an abdomen MRI, including liver, late arterial phase as initial staging, depending upon whether patient has atypical bronchial carcinoma or not, to determine distal metastasis. Additional imaging by DOTA scan can be done. In other cases, the decision regarding somatotropin receptor can be utilized. For confirming diagnosis, bronchoscopic biopsy is recommended prior to definitive surgical resection. Biopsy is advised that it aims for excluding other type malignancies and thus allowing for determining the optimal therapeutic strategy. They found higher frequency of atypical carcinoid, that is 23% as compared to adult, which has 8 to 15% of this. Median tumor size is 2.6 and upper limit was 7.5 months. Data confirms that the bronchial carcinoma in this group of patient is more on right, and 75% in lower bronchi, 10 to 20% in main bronchi, and minor proportion in the lung periphery. In adults, it is typically central, and whereas atypical bronchial carcinoma is more peripheral. None of the atypical carcinoma in this cohort was in main bronchus, and only one had localizing intermediate bronchus. Most patients in these studies had localized disease and metastases were rare. Lymph node metastases were diagnosed in 4 out of 28 patients in this study, which was reported 15 to 30% and 40% in small other pediatric cases. In adults, it is 10 to 21% of patients have lymph node metastasis. This time is up. I just come to the last conclusion. Completely resected localized bronchial carcinoma in children and adolescents seems to have favorable outcome. Compared to adults, atypical bronchial carcinoma occur more frequently. Pediatric patients with atypical bronchial carcinoids are at risk of metastasis and recurrence, and interdisciplinary staging, management, and follow-up is recommended. Close collaboration among all the team members is required. There is no molecular data for this group of patients, and it needs to be determined what molecular alterations occur in this group of patients. Thank you.